Good day, everyone. Today is March 22nd. This is our nursing education in service. We are covering several topics today. There will be handouts in the manual in the CNA corridor for signing and reading the manuals that were for the education, so you can sign up. There will also be this video that will be placed on YouTube so that it can be used to view and then sign the sheet that you have attended the in-service. Topics that we are going to go over today are quite a few. One of the things I wanted to go over was that as licensed staff, we are responsible, and we need to make sure that we are following rules and regulations, policies and procedures, and that we are also documenting, communicating, and managing our team on the floor each shift so that we know that the proper care for our residents' safety is taking place at each time. I'm going to start off by talking about our dialysis communications. This is a mandatory process where we have to send those manuals with each dialysis patient going to dialysis so that there can be documentation on both sides. Once they've been to dialysis, they return with their folder. If they do not go with our folder, and we do have a resident who does not attend dialysis with his folder, we need to be communicating with the dialysis facility for maintaining documentation and obtaining documentation from that facility and filling our portion up on our side. This is our responsibility, so we either need to be calling, faxing, or emailing them. However we do it, we must communicate with the dialysis team in the dialysis facility to make sure that we have the proper documentation after each dialysis treatment for our residents. Next thing is we're going to be establishing what we call Tubing Tuesdays. This is going to be a responsibility of night shift to change out all oxygen tubing, all BiPAP tubing that is oxygen related. This is not the corrugated tubing that they use for attached to the mask. We need any oxygen tubing to be changed out on Tuesdays. It needs to be dated and timed and initialed. And this will be occurring every Tuesday on night shift as a responsibility. That way, every week, we know our tubing is effectively being changed out and monitored. We will add that to the nightly inventory checklist that needs to be done. We also need to be ensuring that each morning the staff are cleaning out the BiPAPs and CPAPs effectively with soap and water, allowing them to dry so that when the residents use them in the evening or later in the day, they are clean and dry and bacteria free, as well as cleaning out the reservoirs and letting them dry as well and filling with sterile water. MAR, TAR, DAR, and BAR documentation is your responsibility. In the dashboard every morning, I do an audit to determine what is missing. And at most times we are effective in getting most of our charting done in those areas. But we are lacking. There are areas that get missed and sometimes significantly missed. We need to make sure that that documentation in all four of those zones, the MAR, the TAR, the DAR, and the BAR, which is behavior, is appropriately documented every shift on every patient. This is a requirement. Proper care planning and progress noting is also the big thing that we need to maintain. We need to make sure that we are progress noting every change that takes place, every refusal that takes place. If a Resident refuses a shower. This needs to be progress noted. We need to identify why they refused, where they offered alternatives, and the outcome. We need to make sure that we are care planning each and every problem that occurs, because we are getting F tags in our survey related to missed care planning of issues that our residents have. And of course, then always following up with appropriate documentation per shift. Shower sheets. These are a requirement. They are not part of the official chart of the resident, but they are utilized by our staff, licensed staff, and our CNAs to identify when a patient requires a shower, if they refused, and that their skin has been assessed and evaluated. Now, this assessment and evaluation of skin is not the responsibility of the CNAs giving the showers or the bathing. They are to identify with the nurses on site that the nurses are viewing and assessing the skin of each resident who is having a shower or bathing so that it can be documented. CNAs can bring to the attention if there is an open area or an area of concern, but this is the responsibility of the licensed staff to be assessing and documenting and following up with progress notes and care plans and notifying of RCMs of any wound or skin changes or alterations. We've missed several opportunities to stage wounds. We have missed when wounds occur. We need to make sure that these are being caught on the day of each shower or bathing. Floor staff assignments. These are made out by the HR. Yes, there are changes that the floor nurses do have to make because there are changes in staffing. People who don't, who call in, people don't show up, no show, no calls. We need to make sure that the nurses, the charge nurses on the floor are managing the team, that your team are the CNAs and the CMAs. You must ensure that they are doing their job, that they are charting in the POC, and that they are documenting any changes, especially in vital signs, and that they are notifying you. You guys are the leaders. You need to be making sure that you are leading and managing the team when they're on the unit. We're finding very frequently missed opportunities or issues or problems that are arising because of missed opportunities for managed charge nurse care and management of the floor team. CMAs, they need our support. They need the floor staff charge nurses support with passing PRN meds. This is a very hard facility to pass close to 60 plus residents 3 times or more a shift or a day with medications that extend longer than 2 hours. Where we're finding issues are the CMAs are having to run back and forth between hallways to manage PRN dosages. This can be helped by the charge nurses and the touch to talk to have the CMAs request your assistance so that they're not having to do as much running and cross unit time wasting so that they can stick to their routine meds. We're asking for your help on the floor. Phone management. This is a responsibility for everyone on the floor, including CNAs. Everyone knows how to answer a phone. A phone should be answered in 3 rings or less. And it has been my experience to call multiple times and nobody answers. One time I was on 45 minutes before anyone answered. That's my own personal experience. I've had periods where it's been 30 minutes. And then I've had times where it's answered very quickly. So I ask that everybody be responsible for answering a phone, especially if you're sitting right next to the phone. I've witnessed people not answering it or responding. All you have to do is answer. Welcome to Avamere. May I help you? Identify who you are. I'm a CNA, I'm a CMA, I'm a nurse. How can I help you? Let me see if I can find that person for you. We need to make sure that we are dealing with these phone calls in a pertinent time frame, because we have family members who call frequently. We have providers who try to call. We have our own staff and management who try to call, and we need to make sure that you guys are available. Insulin dispensing and documentation. We need to make sure that we are documenting appropriate blood sugars, also that we're documenting the appropriate amount of insulins that are being dosed, and that we are care planning any changes or any alterations when a patient's blood sugars are too high or too low, and that the providers are being notified. Kaiser really wants us to be in one-to-one communication with their providers if there are any changes, and we are requiring our staff to treat any age-right or data patient as the same. We need to be prudent and timely on insulin management, snacks, monitoring, and charting, care planning, and again, progress noting. And if you find that your insulins were given and the meal trays are late, we need to make sure that we are passing snacks in a timely manner so that we can ensure that nobody is bottoming out with their blood sugars. Nighttime assignments. I have a binder here that is in a nice purple. It is, sorry, everything's going to be probably backwards in this, but it says crash cart glucometer and med refrig interiors completed by night shift. It has also, we're going to be putting in a sheet for the tubing Tuesdays so that you guys on night shift know your assignments and that you are following up with checks and assessments on a nightly basis for the glucometers, the refrigerators, for medications, and then also for the crash cart. Crash cart has been updated with new supplies by nursing, Kim Hales. She's done a great job, and she has made new inventory sheets that we can check off very easily that needs to be done on a nightly basis. Again, that is a night shift task. Vital sign management. We need to make sure that vital signs are obtained in a timely manner each morning or at the beginning of each shift, that those vital signs are reviewed by the nursing. We are finding that there are abnormal vital signs that are being documented and they're not being followed up by or managed by the CNAs. They do not have the knowledge base to fully comprehend when a vital sign is abnormal or critical. This is where our critical thinking comes in by our nursing staff. You need to be monitoring your vital signs. CNAs need to be managing and notifying the nurses if there is an abnormal vital sign. Documentation and progress notes are also mandatory on this, and provider notification. Strict communication between all levels is important and prudent. We also need to make sure that there are no wrist blood pressure cuffs on the floor any longer. Those are not prohibited because we find that we cannot manage those. They cannot be calibrated and they are not being cleaned from resident to resident. The IV or the vital sign stands that have the blood pressure monitors on them, those have been recently calibrated. They are calibrated on a yearly basis. And so those are managed and monitored officially. So all residents must maintain a blood pressure through manual or through the automated system and recorded. Risk management. This is for the nurses to acknowledge if there's an issue that needs to be care planned, progress noted, and started as a risk management. This needs to take place with start to finish. We need your evaluation, we need the assessment, we need the investigation, we need documentation, we need notification of family, friends, the POA, the patient themselves. We need all risk management tabs attended to. Often these go for several days without any further evaluation. Something happens on a Friday, it isn't until Monday when the RCM comes in and they start doing the investigations. Investigations, witnesses all need to be put in at the time of the incident, the provider, those who were notified, progress notes, and details as much as possible. We also need pain level evaluation. This goes for 3 or 4 days without anyone putting any pain assessment. This is to be completed by all staff who are nursing. FRI reports. I know you guys are not the ones who really actually fill out the FRI reports, but you are the ones who are going to be notifying me or Alan or any of the other management if a FRI needs to be started. A FRI is started if there is neglect, abuse, or an unknown injury. And this could be subject to someone's comments, someone's accusations. We need to start a FRI report immediately. We have 2 hours to do a FRI report. I require that all nurses be available to call me or call Alan and get that FRI report started. FRI report is online, and all it does is require a few questions to be answered and some information to be filled out. There are also paper copies that can be done, but management needs to be notified on a FRI. I've also hung up in the nurses' main nursing area the definitions of neglect, abuse, and some of the things that are considered a FRI responsibility. So this is a responsibility of all nursing staff to notify any of us if there is the potential for neglect, abuse, or unknown injury of some unknown source. They need to be FRI'd. The POC charting there on the dashboard in your in PCC. I'm requiring the nursing staff to follow the dashboard so that they can follow the MAR, the DAR, the TAR, and the behavioral monitoring to see where the documentation is being missed. There are dots, green, yellow, and red. Red means it needs to be completed. Green means it's totally completed. Yellow means it's in process. And it's broken down by floor and by shift. So there's a 100 hall, 200 hall, and a 300 hall for both days, evenings, and nights. Also, I want POC charting monitored by the nursing on staff. This is right next to that daily MAR and TAR documentation. It again follows the green, yellow, red dot system. We are going what we call red to green. We want everything at the end of each shift to be green. We want those dots to be green. We want to make sure that all the floor staff are charting everything that is in the Cardex and in the POC. This is a mandatory charting system, and we are finding that if we have agency or we have lazy staff or staff who aren't consistent, where we will miss an entire unit with nobody being charted on. Nothing, 100% nothing. Some days we have almost everything charted, which is great, and we have improved, but we have a long ways to go in our charting. And this is the responsibility of each nurse working on the unit to manage the floor staff and their documentation in POC. No staff are to leave the floor or punch out until they adequately have completed 100% of their documentation. We are not allowing staff to leave the floor until their their documentation is completed. If they do leave the floor, we are calling them back in, and they have to come in within a 12-hour period and complete their documentation. We will do the same thing for nurses if they have not finished their DAR, MAR, or TARS documentation. This is mandatory. This is something that has to be done. We were cited with FTAGs on this. Preceptor student management. We are privileged to have our facility used by several colleges, Sumner, Concord, Institute of Technology of Nursing, and sometimes George Fox University utilize our facility for clinicals for their staff. Those staff or those students come in with varying levels of knowledge base. Most of them have not had or have had very little on the floor experience with taking care of residents. We need to manage them, monitor them, and ensure that our nurses are caring for our students appropriately. We're following the rules and regulations. We're teaching them the right way to do tasks, charting, monitoring, assessing, reevaluating, communications, documentation, provider notification, taking orders, writing orders, etc., taking phone orders, taking verbal orders. Whatever we do on the floor, we are teaching them the proper way to do it. We do not teach them shortcuts. We do not teach them bad habits. We need to make sure that all of our students are getting the highest level of care in education that they are paying for and expecting. We want our future nurses to be prepared. So please monitor, manage, and ensure that they are doing their jobs appropriately with your management. This is our responsibility. We have taken this on as a facility of Avamere to provide education and training for the future nurses. Goals of success. There is a handout for this as well. Value the power of learning and knowledge, and it will increase your success and growth in your career. Accept responsibility. Challenge yourself to grow and learn and embrace change. Change is always occurring. This is healthcare. We're in a very fast-paced world of high tech. So embrace and learn and accept. Serve and care for your residents. Our residents are why we are here. Please take heed and take pride in what you do for your residents. This is your career. Ask, is it okay or what I want for my family member or for myself? Caring for our residents, we need to make sure, is this what I would do for my own family member? Is this how I would want to be cared for? This is kind of the golden rule for nursing. Do unto others as you would have done unto you. So let's please treat our patients with respect, kindness, and all the legalities following our policies and procedures. Be creative and curious. Improve in your skills and knowledge base to elevate yourself. Maintain your educational level. Maintain your knowledge base. I have seen nurses in my career who have stagnated in their knowledge base and they fail to maintain adequate nursing skills or a level of skill base that will propel them and protect and maintain adequate nursing skills and patient care. Accountability and integrity are how you and your job better your residents. Value your skills and knowledge, but always strive to improve. Support, help, and assist those around you. This is a job that no one does alone. So please always reach out to help, guide, assist, and be there for somebody who may need your knowledge base, your care, your muscles, your strength, your endurance, and be a good reflection of what healthcare and nursing is. Those are just some goals for success. Continuing on. We have residents who we need to manage or monitor or document if they are taking their own medications. During survey, we had residents who had medications, and medications are anything that is over the counter or prescription that is not dispensable by law. So cough drops are not bad, but eye drops and creams and salves are considered treatments and ointments and medicated. So we need to make sure that if patients have vitamins, supplements, creams and ointments and lotions that they're keeping at bedside, eye drops, they have to be care planned. It has to be care planned if they're able to administer safely. Are they being stored safely? Are they being managed safely? And how are we documenting when and how those patients are taking those medications? We had a patient who had several salves at the bedside. Survey gave us a flag because we did not have them identified. We did not have them charted. We did not have them in a controlled environment. We did not have anything care planned in regards to the patient managing her own medications. So we need to make sure. So have your CNAs, even yourselves. If you're in a patient's room, please keep an eye out for what you may see as medications, treatments that are not part of our regimen, but the patients have added to their own. We need to remove those from the room. We need to make sure if the patient is able to take them safely, and that we get this care planned and prognoted and the providers notified so that we can do this appropriately and legally. And especially in this day and age where patients can order their own medications over online, such as from Amazon. We have a resident who is purchasing his own multivitamins and supplements, but yet we had no idea that he was doing this or had them in his room. So we had to prognote this and care plan it so that for his safety and for our legalities, we could manage this. O2 settings, we need to manage and make sure that our patients who are on oxygen are effectively being treated and that they are being hooked up appropriately. This is going back to the O2 or Tubing Tuesdays. We've had too many O2 tubings that are outdated, soiled, found on the floor, are contaminated, are not dated or timed or initialed. We have had residents who have humidifiers who are not attached to the humidifier with their oxygen. We have the wrong tubing in the room. We don't know how old the tubing is. So we need to make sure that when we set this up for the night shift to start managing, that they're connecting it appropriately, especially if a resident has a CPAP or a BiPAP, but then also has a nasal cannula and switches from either throughout the day. It needs to be managed and monitored so that our staff knows how to hook these up appropriately so that we have the appropriate line for the appropriate service that we're providing. Pain management. We need to make sure that we are managing the pain of our residents effectively. We're documenting, care planning, and prognoting it, and that it's all being documented and that the providers are being notified if there's a change in a patient's condition or pain levels or pain management requests. Behavioral monitoring. We have several patients who are on behavioral monitor. We need to be documenting their behavior their actions, their verbiage. We need to make sure that we are care planning this so that we are protecting ourselves legally, as well as that we are protecting the patient and their care and resources. This is a huge area that we got some F tags on, was because they talked to all those residents who are very vocal and very upfront with having concerns, and we need to manage this much more effectively to ensure that our residents who do have behavioral issues are being tracked appropriately. So if you put somebody on, or if they are on behavioral management, we are documenting shift by shift by shift, and that we are documenting that they're refusing care, refusing this, refusing that, refusing certain personnel, making certain statements, using certain verbiage, that we are documenting it. Yes, this is a lot of documentation, but if it's not documented, it never occurred. It's their word against ours. Missed medications. We're having a great deal of problems with medications being missed or late administration. As the floor staff nursing, it is our responsibility to manage the CMAs. Yes, they may be giving the medications, but we are assisting and managing them to ensure that those medications are being given on time and per the regulations. If they need help, we should be out there helping them. They have the Touch Talk, and I have advised them to use the Touch Talk to ask for assistance if they need PRN medication distribution or if they need help. Our nursing staff should be able to assist with med passes or PRN dosages. And with those PRN meds, those nurses need to be reevaluating, assessing, and documenting. Documentation is the biggest issue we have. There isn't enough specifics. We need to make sure we're documenting. Admissions. We are lucky enough to have 2 admission nurses who are working with us. Stephanie Philpott, Monday through Thursday, and then we have Kim Hales, who is on Friday through Sunday. These 2 are doing a great job, but they are not here to do everyone else's job. We are also relying on our floor nursing to help. If there is more than one admit, we wish and we are asking and we're requiring that our floor staff help with those admits, orders, documentation, getting everything taken care of. We also need to make sure that the appropriate PPE and enhanced barrier protections is up on the time that the resident arrives. We've had situations where we've had patients who had infectious diseases. They come in on a Friday. Monday, when IP comes in, that patient has had no infectious parameters placed, and everyone who has gone through that room has contaminated themselves and potentially contaminated everything in the building and at their own home private residence. We must put in place those PPE and enhanced barriers before the patient ever enters our facility. Also, we're asking on admissions that we meet the patient at the door, or at least at the front desk. We escort them to their room. We ensure that the room is set up appropriately and completely, and then it has all the appropriate equipment that patient will need. We ask that you introduce yourself and the staff. We ask that you orientate them to the room, to their call light, to their TVs, to the amenities that may be in the room, and you help orientate the family and reassure the family that they are, that their resident or their family member is being taken care of and will be safe. Again, Kaiser is requiring us to be very much in communications with our their providers. We are also requiring that with our staff to be in communication routinely with DAIA and AgeRight for our other residents and our regular residents. This is a requirement that we communicate any changes in condition or status of a resident so that we can maintain that loop of communication and documentation. I cannot reinforce documentation and communication with our staff, within our staff, as well as all of our providers and anyone taking care of our residents. Call lights. We have the new call light system, which is working very well. It is managing, and we can run reports on our lights. It also indicates on the call screen how many minutes a light has been on, which has really helped visually help our staff dictate and get to rooms quicker. Our average call light answer time for the month of February was 8 minutes and 5 seconds. That is within the parameters. That is great. That doesn't mean that we don't have outliers that are an hour and a half waiting for a light. So even though our average is low, that does not mean that there are lights that are being missed. We need our lights, and I'm talking to nights and evenings especially, answered in a timely manner. No more than 15 to 20 minutes at the max. Otherwise, as soon as possible, these lights need to be attended to and assessed what the residents need and cared for. Also, if a light is on, the off-going staff is still responsible for all lights and care as long as they're still on the clock. Anyone clocking in immediately is responsible for what takes place for residents and their lights. Once you clock in, you are on the clock. You are being paid to take care of patients. We need to enforce that with our staff. We have staff who are clocking out early. We have staff who are clocking out with lights still on that haven't been answered in maybe 1 or 2 rounds. This is a problem. We have risk managements that keep getting open, and I have to open up fries. And if I open a fry on a resident's complaint and there is a staff member attached to that, I have to remove that staff member from their ability to work until a full investigation is completed. So we need to make sure that lights are answered in a timely manner. And this is the responsibility of everybody, but I'm holding the charge nurses responsible as well, because you are in charge of the unit. You are in charge of what takes place on the unit. This is under your license. We require you to manage your staff and ensure that they're doing an appropriate job, their documentation, and that it's timely and it's done in a timely manner. Also, charting. In our charting, we're finding that sometimes staff are using inappropriate words or phrases that seem to be highlighting to survey teams that there's a problem. We need to manage and monitor what we're charting in our documentation to avoid using words that are going to be highlighted in regards to this is an accident, this is an injury, this is, somebody else's fault. This is, we need to manage and monitor our word usage in documentation to limit the severity of, because they like the word accidents. Accidents should never be used in documentation. Please monitor what you're documenting. Don't limit what you're documenting. Just limit some of the verbiage or danger words or phrases. We also have a new manual on the floor called Accident Investigation Manual. It's a large red manual that is kept at the desk. I know this is probably upside down for you guys, but this manual is at the front desk, and this is to be utilized by our staff. It has a inventory sheet at the beginning. It is for fall interventions, alleged interventions or of allegations, falls, skin impairments, choking impairments, elopements, unexpected deaths, which we did have one of those, so this packet would have been great. There are packets in here that you just pull, you answer the questions, you do the interviews, and you turn it in. So I advise everybody to go through this packet, this binder, and make themselves familiar. So if there is a situation, you can look at it and you can obtain the information that you need to do for appropriate documentation and interviews for your documentation. Telsure. I've also made another small binder. It's in a lime green. This is for, it's fairly small, thin. It is basically how anyone coming into our facility as a new nurse or as an agency nurse can log into Telsure so that they have access. And all they need to have to get into Telsure is a PCC login. There is one sheet in there that will talk them through. There is a phone number that they call afterwards, and they can gain access with just a few minutes. So I require that everybody be familiar with that. So if we have agency on the unit, they can get access to Telsure. Kaiser is requesting that all staff who are working the floor as nurses have access to Telsure so that we can obtain orders and not miss any documentation that is coming from the providers. F-tags in the binder that I will be providing up at the front desk. I have all the F-tags that were, sorry, this is kind of hard to get. F-tags, sorry. F-tags for what our facility had. There were 34 F-tags and 1 G-tag, which was a harm tag. We did not gain another star, which we really thought we would. We are still at a 1-star status. We still have our red hand, but we are moving forward. We are making the corrections. You may see us all doing audits. A lot of audits have to be done, and they have to be done for several months. And we will have, within the next few days, we will have state back in to evaluate what we have done. So I encourage everyone to please read the F-tags and then also manage what they're doing on the floor appropriately. We have to be legal on everything we do. Documentation and communication is the key. Staff communications. We talk about communications all the time, but we still seem to have a difficult time communicating between departments, nurse to nurse, nurses to CNAs, CNAs to nurses, CMAs to CMAs. We need to make sure that everybody is on an open page with a relationship to communicate appropriately for your profession and at the level of skills. We need to make sure that everybody is on the same page and that we are not missing somebody in the process. Patients are complaining that they feel they talk to us, but we don't listen or we don't hear. We say the same things about our fellow staff members. We need to open up our ears and listen to what each other says, and communication will help us move forward. As I said before, if it's not charted, it's not done. And we have a lot of things that aren't charted that seem to not be done. One of the things that we're not charting is we got patients on antibiotics, but we aren't having any diagnosis that follows the reason the patient's on an antibiotic. And then we're not following up with daily charting or skilled or alert charting on our patients. We need to be charting on a daily basis on our skilled and on our alert. If there's a change in medications, those patients need to be on 72 hours of documentation for med changes. If there's a change in condition, they're on for 72 hours for change in condition. And if that condition worsens, then we continue to monitor. And again, we communicate with the provider and the support staff so that we can maintain their care and stabilize and improve their health status. Last thing I have on here is pharmacy. We need to make sure that we are adequately contacting on each admission the pharmacy and getting meds delivered on an appropriate time. We're having patients admitted on a Friday, but we're not getting any of their meds, or a few of their meds are spotty through the whole weekend until Monday. Patients are complaining they're not getting their medications until Monday when the real staff comes in. Weekends should not see this drop in a cavernous abyss. We should be bridging the Friday through Monday perfectly. There should be no change in level of care in how our nurses, CNAs, and CMAs function. It is the responsibility of our nursing staff to maintain that bridge of success so that our residents are not complaining about their meals, not complaining about when they're getting their meds, not complaining that this wasn't followed, that wasn't answered, this wasn't taken care of. Monday should not be a reconstruction day because the entire weekend fell apart. Our nursing staff must maintain an adequate, thorough, stabilized healthcare system 7 days a week, 365 days a year. Sorry about that. On your pharmacy orders, get them refilled. Contact the pharmacy, get stat orders, utilize what's in the Cardex. Utilize what's in the e-kit, utilize what's in the IV tote. We will be potentially taking on patients with TPN. We have all gone through the TPN training. You have the TPN compliancy that you signed. Please familiarize yourself with TPN again, because we will be taking on higher level of care patients. We are striving to now go to 68 patients in-house. We are right now at 62. And again, right now that fluctuates depending on how we are with admits and discharges. But the goal is 68. That is our maximum. And that is what Kaiser and Avamere is requiring, is that we carry no less than 68 patients. Right now we are carrying 62, and again that fluctuates up and down depending on admits and discharges. So weekends will be our admit times. Monday through Thursday will be our discharge times. So weekends is our big push for admits. That doesn't mean admits will not be coming in through the week, but potentially the weekends are admissions and Monday through Thursday are discharges. We have a really good working team with nurses. We have a strong team. We just need to tighten the belt and ensure that you guys are all on the same page and that we are documenting, communicating, and providing the care that these residents came for and need and deserve. All of these materials will be at the in a purple crepe paper binder over by the CNA area for going through and signing. This will also be on YouTube for you guys to manage and view as well. Hopefully this was educational. Hopefully this will help manage our time and our success. This is a time of growth. This is a time of moving forward. And I have faith in all of our nursing staff, our CNAs and our CMAs. And I want to propel you guys all forward and stabilize us and keep us moving in the right direction with our patient care. One quick caveat is please make sure that your nursing licenses are up to date, and if they are coming close to being due, which is every 2 years, and it's usually on an odd year for your birthday, please make sure that you are going through the Oregon State Board of Nursing and getting your licenses updated and turning those into our new HR person, Jessica. She is running a tight ship with her management of payroll and other paperwork that's required for our staff. So please make sure that your licenses are up to date. Thank you very much, and I appreciate your time, and have a really good day. Thank you.